Yeah, hello, hello everyone. Can you, if you can hear me, just type a message in the message box in the very bottom of your screen. We're getting ready to get started.
Okay.
Okay. Okay, hello everybody. Good evening and welcome to our last webinar for the year. My name is Nay Nyamboli. I will go ahead and just say a little bit about myself, and then I will introduce our presenter for today. And then after that, we will go through the questions, and then after that, I'll have our presenter go ahead with the presentation. So I'm Nay Nyamboli. I'm a pharmacist. Been working for 6 years. Graduated 2013 from Texas Southern University in Houston, Texas. I work as a community pharmacist with the Walgreens Pharmacy of Companies. I'm married and have two kids, 3 and 4, who keep me on my feet constantly. I am actually honored to be part of this association and also to serve with the education committee. All right, so thank you all, and we're looking forward to an awesome presentation this evening. So our presenter for tonight will be Dr. Helen Ashutanteng Array, and I will go ahead and give a brief biography for her. So Dr. Helen Ayuk Ashutanteng Array is a clinical pharmacist with the Indian Health Service, currently in Arizona. Um, After working on MTM services for Walmart Central Patient Services, prior to WPCPS, she worked for Rite Aid Pharmacy for over 6 years as a community pharmacist and MTM specialist. Helen holds a certificate in patient-centered diabetes care. As a diabetes educator, she quickly realized the need to educate and sensitize the community on kidney disease and its causes. Her interest in kidney disease led to her becoming a National Kidney Foundation. She is also a certified kidney educator with the American Kidney Fund. Helen obtained a dual bachelor's degree in science in biochemistry and chemistry from the City University of New York before moving to Yale University School of Public Health, where she studied international health. She completed a Doctor of Pharmacy program at the Albany College of Pharmacy. She is a registered pharmacist in Cameroon as well as in 7 states in the United States of America. And she just recently graduated with a master's degree in patient safety in medication use from the University of Florida School of Pharmacy. So I will go ahead and hand over to our presenter, to Dr. Ray.
All right. Thank you, Nay. Good evening, everybody, and hope you all had a wonderful Thanksgiving. And can everybody hear me? Can you hear me, Nay? Can you hear me, Anne?
Yes, I can hear you.
Oh, okay, great. All right. Okay. So we're going to go ahead and jump right in. So we're going to talk about medical marijuana or medicinal marijuana, which I'm sure we all know it's like a hot topic right now. So marijuana is also known as cannabis, and pretty much it's a psychoactive drug from the cannabis plant, which is used for recreation or for medicine. But we're going to focus more on the medical use of marijuana. Okay, and so a few objectives today. And upon completion of this activity, we should be able to review the basic and clinical pharmacology of the naturally occurring marijuana and the synthetic marijuana, so the one that is done in the lab, and what it is made up of. You should be able to list the various types and the various formulations of medical marijuana that are available to the patient. You should be able to discuss a number of the possible uses for marijuana. And I'll have a link where you can find all the clinical studies regarding the effectiveness of marijuana. And lastly, you should be able to recognize the potential physical and psychiatric side effects. So pretty much side effects and drug interactions that may occur with the use of marijuana. All right. So what is medical marijuana? Pretty much as earlier stated, um, marijuana is derived from a plant, and the two types of plants, which I'm going to go into on the next slide, the two species that are commonly known and have been well studied, and those would be the cannabis sativa and the cannabis indica. The one that is most common is the sativa. It's grown worldwide, and it has very tall plants with very long, thin, light green leaves. And I think that's the leaves that most people recognize. And I'm just going to go back to the slide so you can see that what it looks like. It's thin and it's long. It has a very unique structure, the way it looks. I think I went a little bit too far. It's used for fibers to make clothing, rope, believe it or not, but it's also used for its psychoactive properties. And the sativa plant has a higher ratio of CBD to THC. And we'll talk more about that, what the CBD is, which is pretty much the cannabidiol. And then we have the THC, which is the tetrahydrocannabidiol, but we'll talk more about it. Then you have the cannabis indica, which is more common in the Middle East, India, and Central Asia. The plants are shorter and the leaves are darker and they're broad. They're not as thin and long as the other one that I showed earlier. I should have put a picture, but you can find it on Google. Sorry about that. And it's mainly used for its psychoactive properties, unlike the sativa, which is used to make clothes and ropes. And the indica has a higher ratio of the THC compared to the CBD. And so, talking about the CBD, the cannabidiol, and the THC, those are just two components of marijuana. Now, there's several chemicals that are found in marijuana, but the two that has been studied the most is the delta 9 tetrahydrocannabinol, which is known as THC, and I'm just going to refer to it as THC from now on. And then the cannabidiol, which is known as CBD. So those are the two that I put in red because those are the two that is most studied and is most known. So the different types of cannabinoids. You have the endocannabinoids, and you have the phytocannabinoids, and you have the synthetic cannabinoids. So I'm going to talk about the plant-derived ones, which would be the CBD, the THC, which we just mentioned, and then you have one that is made in the lab, and that would be something like Marinol, which most of us know in the pharmacy. It's a C2, and you have the Sisamet, which is a C1, and then you do have cannabinoids, which have the same properties as the cannabinoids in marijuana that are naturally occurring in our body. And so far, two types have been studied in our system, and it's the anandamide, or it's called the AEA, and then the other one is the arachidonyl glycerol. So the two kinds of naturally occurring cannabinoids. And then you have the two most studied in the plant, which is the CBD and the THC. Then you do have the synthetic one, which is produced in the lab, and that is the Marinol or the Sisamet. And then you have a new one, which we'll talk about it as we go along. And another thing to keep in mind is that our bodies, the human body, does actually have what is called the endocannabinoid receptors. And so I think it was back in early 90s when they discovered that our bodies do have the endocannabinoid system. And we do have the naturally occurring chemicals that they do look like the plant derived cannabinoids, and they could bind to the receptors that we have in our system. So we do have two receptors. One is called the CB1 and the other is the CB2. The CB1 receptors is found mostly in the brain, a few of them in the peripheral, but mostly in the brain and in the spine. And I'm going to show a picture as we go along. And then you have the CB2, which is found mostly in the peripheral part of the body, the immune system. And so the natural endocannabinoids, like the AEA, is meant to bind to these receptors. But because the plant-derived ones, the THC and CBD, looks pretty much exactly like the natural occurring endocannabinoids, it has the potential to also bind to the same receptors that we have. All right. So we're just going to talk briefly about the synthetic cannabinoids, and those are the ones that are FDA approved. So we do have Marinol, which is a C2, and that one is used to treat nausea and vomiting caused by cancer. And it's not a first line, it's a second line. So after everything else is failed, then you resort to the Marinol. And I just want you to keep in mind that the Marinol is a synthetic THC. So it is done to be exactly like THC. It is not similar to the CBD. It is also used as an appetite enhancer for patients with AIDS who suffer from weight loss and have poor appetite. It comes in capsule form and oral solution. And just keep in mind that the oral solution does come with a calibrated dosing syringe. You want to make sure you use that when you're dispensing the medication. It's really, really important to avoid inappropriate or inaccurate dosing. And just something to keep in mind when you dispense a prescription for Marinol, the first dose should be given on an empty stomach, and you want to do so about 30 minutes before eating. And the subsequent doses within a chemotherapy cycle can be given at any time, but the first one is really important that you do so on an empty stomach, 30 minutes prior to eating. And for patients with AIDS, for appetite purposes, you want to do that 1 hour before lunch and then 1 hour before dinner initially. And if they have side effects, experience side effects from there, you want to do it 1 hour later on in the day, so 1 hour before dinner and at bedtime, because it might help to reduce the frequency of the adverse effects. And then the other FDA approved synthetic cannabinoid is the Nabilone or Sisamet, and that one is Schedule 2. So it's also a synthetic THC. The Marinol is Schedule 3 and the Nabilone is Schedule 2. It is more potent than Marinol, and that explains why it is Schedule 2. This can be taken by mouth to treat nausea and vomiting caused by cancer chemotherapy, just like the the Marinol, and it's also second line. So when everything else is failed. And an interesting fact about this is that it can increase pain rather than decrease in pain. I know most of us know that marijuana, usually when they talk about its use um, on the street, they talk about for pain. But this nabilone actually can cause an increase in pain rather than decreasing it. So if you have a patient who is receiving chemotherapy and is suffering from nausea and vomiting, and this medication is prescribed, you want to let them know that there's a possibility that they may feel more pain than less pain when they take this medication. So it helps with the nausea and vomiting, but then it increases their pain. Then the most recent FDA approved cannabinoid is actually the Epidiolex. This one is actually a synthetic CBD, unlike the Nabilone and the Marinol, which is a synthetic THC. And this one was approved for treatment of seizure disorders that's associated with some different forms of epilepsy, pretty much childhood epilepsy. And it's the first FDA approved drug that contains the CBD, since the other two were THC products. And for the dosing, I didn't put anything in here, but that's because it has a wide range and it needs to be titrated. It needs to be titrated, and is weight based also. And some of the side effects here are just sleepiness, a decrease in appetite, diarrhea, an increase in liver enzymes, just feeling very tired and weak, and rash, sleep problems, and possible infections because it's going to affect your immune system or lower the threshold. So it's easy to have an infection. So the question now is, how does marijuana work? So to know how it works, you have to understand the endocannabinoid system, which we had touched on earlier on. So the endocannabinoid system is really important in maintaining balance in almost everything that we do. The endocannabinoid system, it does affect it's it does use endocannabinoids, which are neurotransmitters, just like serotonin and dopamine. So the chemical messengers of the nervous system. So that's what the endocannabinoids are. So when anything that affects the endocannabinoid system is going to affect affect neurotransmission, just the way that serotonin and dopamine works. The system, like I mentioned, is made up of CB1 and CB2 receptors. And these receptors are activated by the two endocannabinoids, the anandamide and the 2-arachidonyl glycerol. The anandamide stimulates the CB1 receptors, which I mentioned earlier that it's mostly found in the brain, the spinal area, hypothalamus, the cerebellum. And then the 2-AG stimulates both the CB1 and the CB2 receptors. So the CB1 activation would control several physiological functions, so like sleeping, appetite, vomiting, mood, pain perception, and memory. So anything that activates the CB1 or prevents activation of CB1 is likely to affect your sleep, your appetite, vomiting, mood, pain perception, and memory. Meanwhile, for the CB2, activating the CB2 helps to control inflammation. And remember, the CB2 receptors are found predominantly in the periphery and the immune system. So if you know where the CB1 and the CB2 receptors are found, it's quite easy to understand how marijuana works in the body by knowing where it binds. So I mentioned that the two most studied cannabinoid in plant is THC and CBD. So THC binds to the CB1 receptor, while CBD binds to mostly the CB2 receptor. So from that, you can see how they work. Okay, so this is just a picture that I got from a CBD school. They actually have a school. And so the THC is the mustard looking key, the tetrahydrocannabinol. So it does open the receptors of CB1. Then you have the the CBD, or here they have it as a CBN, which does open the CB2 receptors. And you can see the picture where to the left, well, yes, to my left, that is just showing you a synapse right there, neurotransmitters and the receptors, shows you where the cannabinoid receptors are, just so you get an idea. And then if you look at the picture of the person, you can see little dots on them. The little green ones are the CBD receptors, and then the mustard ones are the THC receptors, which you can see that are mostly around the brain and then coming down towards the around the spine. And also, one thing to know is that the CB1 receptors the CB1 receptors, interestingly, you don't have them around the part of the brain that controls breathing. So that's why it's kind of hard to have someone have like an overdose of marijuana where it does affect the breathing, um, unlike in the case of opioids. And here, I just wanted to show a picture so you can see the similarities between the anandamide, which is a naturally occurring cannabinoid in our bodies, compared to the one of THC, which is gotten from a marijuana plant. You can see that they're very similar. And that's what makes it really easy for the THC to be able to bind to the receptor that is meant for an anandamide. And this picture just pretty much gives you an idea of the various places where marijuana works. And remember, I had mentioned that the effect you get depends on where the receptors are in the brain. So you see the cerebellum, the brainstem, spinal cord, hippocampus, hypothalamus, all those parts that are labeled do have receptors. So, for example, I'm not going to go through all of them, but I just pick a few so we can look at. So you have the amygdala. The normal function is to regulate emotions, fear, and anxiety. When THC binds to that receptor, it causes panic, it causes paranoia, because it heightens the normal effect that would happen. So the fear and the anxiety gets magnified. So it causes panic and paranoia. Um, let's look at the cerebellum, which controls the motor coordination and balance. When THC binds to the receptors in the cerebellum, it affects coordination. And that's one of the reasons why using marijuana and driving is a no-no. It increases the chance of accidents because it does affect coordination. The hippocampus, which normally regulates learning new information, that is affected by THC because it does impair memory. The hypothalamus regulates eating and sexual behavior. When you take THC and binds to the receptor, you experience an increase in appetite, both for eating and for sexual behaviors. So, what are some of the medical uses of marijuana? I know we had already mentioned the three approved ones where they were used for nausea and vomiting, and then for epilepsy, but those are just the FDA approved. Now, in states where the use of marijuana for medical purposes is legal, there are many other uses for marijuana besides the nausea, vomiting, appetite enhancer, and for epilepsy. So we're just going to go through a few and then see if it works or if it doesn't. So chronic pain. according to statistics which I got from AARP, they found that more than 600,000 Americans do use cannabis to relieve pain. And we all know the number might be more than that because it just depends on who reports it or not. And there's definitely some scientific evidence to show that marijuana or cannabis is effective with pain. However, more studies need to be done to conclude that it is actually effective. And what they found out was that the cannabis did reduce pain by about 40% in a study that was done for patients with neuropathy experiencing pain. Some patients who had HIV, cancer, chemo, they did find out that it did reduce pain by 40%, but more studies are needed. And also, a study was done in Canada, but it was done for, it wasn't done in humans. I think it was done in rats as well. And then it did show that it helped. Then they had very little evidence in humans to help arthritis. However, the people who use it, they do say it does help, but in some cases they say it doesn't help. So you have conflicting results with the effectiveness. And they said overall 79% of the patients did say it helped. But one thing to keep in mind is that when I looked at many studies, for every two studies, one says it helped, one says it doesn't. So it's really very a lot of mixed reviews when it comes to the effectiveness in with chronic pain. And I have a link, which is I think I have in one of the slides coming up. It does show so many studies that have been done, and you can go through them to see. So it's kind of hard to conclude if it's very effective in chronic pain or not. But the bottom line is that it does seem to help. So if you have a patient that comes to you and tells you that they do have chronic pain and they would like to use cannabis for their pain, what you want to tell them that it does seem to help. Does it really help? It looks like it's a perception. It may help, it may not help. They could try it, but there's no guarantee. Insomnia. Another study was done in Colorado, and more than 1 in 3 people said they used it for sleep. About 86% of the people said it did help. The THC and the CBD, so the whole plant, without being isolated, the whole plant seems to help in the short term. However, in the long term, it's a problem. And in the long term, it's a problem. Most of the people who said it helps, they do have issues with pain, fibromyalgia, or anxiety, and they said it helped to an extent. But one thing that you want to keep in mind is that the THC actually could keep you awake. So when you do the whole plant that contains the CBD and the THC, it's a little tricky because the THC can keep you awake, the CBD can help. But how do you quantify how much CBD is in a product versus how much THC is in the product? It's not. So that's a problem right now because it's not quantified to know the right amount of THC that's needed versus the right amount of CBD that is needed. And therefore, we need more studies to be done to actually identify how much of the product could help with sleep. So the bottom line, just like in chronic pain, it seems to help. It's not a definite yes, it's not a definite no. So that's something that you want to keep in mind. If you recommend cannabis for sleep, it seems to help. It also depends on the individual. It depends on the content of the product they buy, how much THC is in it, and how much CBD is in it. But remember, these products are not regulated, so it's kind of hard to know how much of each component is in the product. Now, they may say so on the packaging, but there's no way to find out if it is actually true or not. The next, so we're going to talk depression, anxiety, or post-traumatic stress disorder. You have a lot of patients that use this, they use the cannabis for these purposes. And according to a study that was done, about 90% of the patients that used it, they said it did help with the with depression and anxiety. And once again, like every other thing, there's not enough data that's available out there to conclude that it does help. And in an online survey that was done by the Washington State University, they did find out that about 3,000 of the users actually use it for depression, and they did say there was some improvement, but it was short term when you use a product that has a low THC and a high CBD. And once again, we come back to the same problem. How do you know how much THC is in the product versus how much CBD is in the product? So, not being able to determine that, it's kind of hard to conclude if it helps or it doesn't help because you don't even know what product that they're getting. So, the bottom line, I guess I didn't put this here, but it does seem to help, but there's no guarantees. And just one little story. I had a patient the other day who suffers from diabetes and hypertension, and I realized they haven't filled the medication for about 6 months. And when I asked her what was going on, she said, "Oh, I decided to get a weed doctor, and the weed is working really great. My diabetes is gone, my blood pressure is gone." And she sounded really excited and very happy. And I asked her, "So what's your A1C?" She said, "I don't know." "What's your blood pressure now?" "I don't know." "When was the last time you checked them?" She said, "Oh, about 8 months ago." And she said, "But I feel really good. I feel really, really good." And she was like so excited. Her voice was like loud and she was just so excited. But you want to keep in mind that this medication can get you high and euphoric. And I'm not so sure if it's that the diabetes is gone or the hypertension is gone, or if it's that the effects of the marijuana is probably just making her happy and she doesn't feel any of the effects of the diabetes or the hypertension. And I did explain to her that the only way you would know if the diabetes is gone is if you check your sugar and if you go check your A1C or if you check your blood pressure. That's the only way you would know. And she agreed to go back to her doctor for a checkup. So if you have any of those patients and they tell you that everything is gone and they have no clue what their A1C is, what their blood pressure is, or cholesterol numbers, please encourage them to go to the doctor and get it checked. I don't discourage them from using the weed, but I tell them to combine it with their regular doctor, what they're doing, um, together to see that it's effective because hypertension is a silent killer. One fine day she might get up and then stroke out and we'll never know what happened because she thinks that she's fine. So it's just to keep that in mind. And so some of these patients that say it works for pain, it works for insomnia, it works for depression, maybe it just makes them happy, so they forget their troubles and they think it's actually working when it might not be working. It might just be masking the situation. Then we have the multiple sclerosis. You have over 1 million Americans right now are suffering from multiple sclerosis, and they are the second largest group besides those who use it for pain that use marijuana for spasms. And there's enough evidence right now to show that it can help to reduce the muscle spasms. And I think they have a spray, it's called the Sativex, which can has been known to help. So, but there are more studies that need to be done to actually conclude if it helps or not. But so far, it does seem to help. And then, so we have cancer pain, and it is very effective in cancer pain, according to some patients, when they were when some patients were asked. But more importantly, it is very effective in nausea, vomiting, loss of appetite, and weight loss. And for now, that's like the only use that has been approved by the FDA for marijuana, the Marinol and the Sisamet. Those two have been used for nausea and vomiting associated with cancer, chemotherapy, and also for loss of appetite and weight loss in patients with AIDS. And so it does help. Some patients will tell you it doesn't, but the bottom line is that it does seem to help. So, what is the pharmacokinetics of marijuana? It's important to understand the pharmacokinetics of marijuana or cannabis, just because when we talk to our patients, we need to be able to explain to them um, drug interactions with other medications. And this is just like a little review of pharmacokinetics, the principles of the ADME absorption, how it gets in to the system, distribution, where it would go, um, the metabolism and how it's broken down, and then of course the excretion and how it leaves, and because all of that would affect the way um, how it interacts with other medications. So the Marinol or dronabinol or nabilone, it so for the marijuana or cannabis, you have different forms so that you can take it orally. The dronabinol and the nabilone, those are the FDA approved ones. And then you have the edible marijuana products, which are sold out in little marijuana dispensaries. So they come in cookies, brownies, cakes. They come in all different forms. So when taken orally, they have a very, very extensive first pass metabolism. And they do involve the cytochrome P450 system, specifically the CP2C9 and the 3A4. About 20% of the I'll call it the drug reaches systemic circulation unchanged. And it usually takes about 30 to 60 minutes to achieve an effect. Depends on what form in which you take it in. And then when you smoke it, it's really, really quick. The onset of action, it takes effect within seconds. And the bioavailability of the THC, it varies according to how deep you inhale when you're smoking it, and the duration of the puff. And so when you inhale it and then you hold it, you hold it, the longer you hold it, the more it gets into your system. If you puff it and you don't, or exhale for too long, just a little bit, then you get more in your system. A very deep inhalation also gets it into the system more than a very shallow inhalation. And bioavailability is about 10 to 25%, and 50% of the content is it goes into your system, and 60% of the smoke may be metabolized in the lungs. And more studies are beginning to find that when you smoke it, it also may affect the lungs just the way tobacco does. They're finding a lot of issues with patients with lung problems from smoking marijuana. And as mentioned earlier, the onset of actions is within seconds. You reach peak concentrations within minutes. And it takes a very, very long time to leave the system. The half life is almost more than a day, about 30 hours. And the vaporization, so they have a lot of vapor bars these days, and some people go to these bars and there's marijuana that's also inhaled. And the vaporization is pretty much like smoking, because what happens is that it gets put in the little beaker and then it gets heated up. And so it gets heated up and then it ends up becoming a vapor. So it's like smoking. So the effects are pretty much the same. So then more on the pharmacokinetics. So, and remember, we're just talking about the THC, not the CBD. And I mentioned that the THC has a very extensive first pass metabolism. So it's metabolized by the cytochrome P2C9 and 3A4. So it's an inhibitor. 2C9 inhibitors may keep THC longer in the system. So it's going to reduce THC elimination. So you want to watch out for medications that are inhibitors. So if you have a patient who tells you that they smoke marijuana and they take medications that are 2C9 inhibitors, you might want to explain to them that it might cause the THC to last a little bit longer in them, so the effect might be longer. There might be some patients that might actually like that. I don't know, but it's just something to keep in mind. And you have some people are poor metabolizers of THC than others. So if you're a poor metabolizer, then the concentrations would be even higher than someone who is a normal metabolizers. And you have the whites more than the blacks, and then the Asians. So something to keep in mind if someone comes to you and talks to you about wanting to take marijuana for a medical purpose. So if it's a white person, a black person, or an Asian person, you could advise them maybe the amount that you want to take. As a white person, you might want to drop it down a little bit because it might last longer in your system. And like I mentioned earlier, sorry, the smoked marijuana, not the oral one, can also lead to an induction of a CP1A2. So if somebody is taking olanzapine, clozapine, tizanidine, duloxetine, and they smoke marijuana and they tell you that they do smoke marijuana, you want to let them know that marijuana is an inducer of 1A2. And so these medications are metabolized by 1A2. And so if it does induce that cytochrome P1A2, it's going to increase the clearance of these medications, and they're not going to get the full effect from these medications. But it's not the same if it's an oral, if they're doing it orally, but if it's being smoked or even through the vapor method, it's the same as smoking. So it's still going to have the same effect. So what are some of the pharmacodynamic interactions? So marijuana does have sympathomimetic activities. So it can cause tachycardia, which can also cause hypertension. It's a central nervous system depressant, so it can lead to drowsiness. So if you have medications that cause some of these side effects, you know you're going to have an increased experience increased side effects, the tachycardia, hypertension, drowsiness. It does have anticholinergic effects. So anybody taking any anticholinergic medications, you're looking at having increased drowsiness, dry mouth, blurred vision, and a diminished short-term memory. So it's important to let them know if someone is taking, say, amitriptyline, and they tell you that they're taking marijuana, you want to advise them to watch out for an excessive dry mouth, blurred vision, diminished short-term memory. If they're taking any muscle relaxant that could cause drowsiness, then they might experience an increase of that side effect as well. And I just had like a little chart here so we can see. And these are just published reports of drug interactions. And I got this from the FDA, which I had a link there if you wanted to get that. It's a little chart that is good to have and keep, especially if you do come across a lot of patients who do use marijuana. It just tells you the drug, and then it tells you the clinical effect that you can get. So for example, like I mentioned, you have something like benzodiazepines, alcohol, opioids, Buspar, any antihistamine. With marijuana, you have an additive drowsiness and CNS depression. And you have something like theophylline. So if you have someone who's using theophylline for asthma or COPD, and they tell you that they're taking marijuana also, there's an increase in the theophylline metabolism that has been reported with smoking of marijuana. So what happens in that case? They don't get the full effect of the theophylline. So this is like a little nice chart that I would recommend that everyone should have, just in case you have a patient that uses marijuana and they want to ask you about the other medications that they take. If there's any interactions, it's a little quick reference chart that you can go to. And this is the link I was talking about that it gives you a summary from various studies. There's so many studies, there are hundreds and hundreds of them. That's why I did not bother to put them here. If you just go to that link, you can read about almost any study that has been done for all the different conditions. And it has over 100 studies there, and it will tell you what the findings, and it'll be very interesting to look at them because, like I said, you might go through two and it gives promising results, and then you go to the third, fourth, and fifth, and the results are not consistent. So the bottom line when it comes to the use of marijuana for medical purposes is that we need more and more research. Unfortunately, because federally the drug marijuana is not legal, it makes it hard for it to be studied. So I guess the federal government will have to come with laws that make it a lot easier to acquire marijuana for study purposes. All right. So most of the presentation so far was on THC, which is the delta 9 tetrahydrocannabinol. And so I'm just going to do a little focus on CBD. And remember, I said we have two receptors, the CB1 and the CB2. The THC binds to CB1 and the CBD binds to CB2. And the reason why most of the focus is on THC is mainly because when you go out there to a marijuana dispensary to get the marijuana for medical purposes, it's a combination product, or as THC, that we're referring to, not so much the CBD. Now you have the whole craze about CBD, and the CBD alone is known not to get you high. And that's because it binds to the CB2 receptors, which we know it's not in the brain area. And that's why it's known not to cause any high. Um, for the most part, a CBD product does not have THC in it, or it should not have THC in it. And some of them may, but if it has like a teeny little bit of THC, it shouldn't still cause any euphoria. However, it's kind of hard to determine what is out there if it does have THC or not. So a lot of products are being sold as CBD products, but it may have some THC in it. And like mentioned earlier, it's not controlled. So there's no way to tell what is in it and what is not in it. And I'm sure most of you have had your patients coming to you asking you about CBD oil and all the CBD craze that's going out there. So it's good to just equip yourself with some information so you know how to answer the patients. And so CBD is okay for some conditions, but it's not for others. We had mentioned one that has been approved, and that's the Epidiolex, and that's used for childhood epilepsy, and is only approved for that condition. Now you have CBD being advertised for several conditions. Keep in mind that it has not been FDA approved for any of those conditions. It may be useful for different types of chronic pain, especially joint diseases. And remember, we mentioned that the CB2 receptors are found in the periphery, so it can be helpful with joint diseases. It may be helpful for sleep disorders. So you hear that it's infused in pillows. The pillowcases now that have been infused with CBD for insomnia, it may be helpful. It may also be useful in treating anxiety. But you want to keep in mind again, it's kind of hard to know what is in the bottle. And the good thing is the FDA does have a website, a link, I think it's on their website, with warnings of various CBD manufacturers to watch out for, because they are marketing the products as being, I would say, organic or pure CBD when it's not. And I did mention the study that, not really a study, but a report from the Utah Department of Health researchers, and they had mentioned that cannabinoids that were marketed as CBD were likely to have caused about 52 poisonings in Utah in late 2017 and early 2018. And I'm sure there's more now because the CBD craze has just gotten even more than it was before. As a matter of fact, the Virginia Commonwealth University also study also found that they did find a very dangerous synthetic product, as well as dextromethorphan in one of the CBD vaping products. So it was not just CBD in it, it had other things in it. So you want to advise your patients to be very, very careful when they buy the CBD products, because it may not have what it says it does have. And a little bit of THC is okay in CBD. Because one thing that I did not mention is that, interestingly, CBD has been found to help reverse some of the euphoric effect of THC, but only in small amounts. So if you take a product, say from the cannabis indica, which I had mentioned earlier, which is the other kind of marijuana plant that has the darker leaves and the shorter leaves, it has a higher THC ratio than the CBD ratio. And in that case, it's hard for the CBD to counter the effect of the THC because the THC is more than the CBD. But if you have a product, a CBD product that does have a little bit of THC, it's sometimes okay. So you get the positive effects of THC, and then the CBD takes care of the negative effects of the THC. So it's okay to have a little bit of THC in a CBD product. And so pretty much this is just a summary of the difference between the THC and the CBD. The THC has psychoactive effects. Um, it's a potential agonist of the CB1 receptor. It binds to both CB1 and CB2. It's illegal, as we know, on a federal level. It's found only in the cannabis plants. It increases appetite, can cause anxiety, and is used as a sleep aid. And then you have the CBD, which is the cannabidiol. It's non-psychoactive, and that's because the receptors are mostly not in the brain area, and this suppresses both CB1 and CB2. It's more legal at federal level, and that's why you have it being sold everywhere. It's found in cannabis plants and the hemp plants. So the THC is only found in cannabis plants, and the CBD is found in other plants. It reduces appetite, and you can see the opposite. The CBD reduces appetite, the THC increases appetite. The CBD can help to reduce anxiety, the THC can cause anxiety. The CBD can keep you awake, while the THC can help you sleep. So it's kind of hard to, so if you buy a product that says a CBD product because you want it to help reduce anxiety, and it does the opposite, there's a high chance that the CBD product contains a whole lot of THC. So those are some things to keep in mind when your patient comes to you and tells you that, I want to buy CBD to try it for sleep, of sorry, to try to help to reduce anxiety. You want to let them know that if they realize that it's not helping, it's actually making them more anxious, then that product is not as pure as it says that it is. So it's always good to look up in the on the thing, the FDA website. So if you want to buy CBD and you go to FDA website, it's going to tell you which manufacturers to stay away from because they've already been known to not deliver what they say they do deliver. And so I have the link here. I call the staying in the know is the FDA link. It has warning letters and test results. They actually tested some of these products to see if they contained what it says it contains, and if it was found that they did not have exactly what it said it does have. I was trying to see if I could click here. I'm not so sure if I could. Nay, if you could, to click it and we can see the link. But that brings me to the end of the presentation, and there's still more to be studied. There's still more to be known about the use of marijuana in for medical purposes. So if you have a patient who comes to you asking about CBD, please send them back to their doctors. They need to discuss with their provider before they go on to use the CBD. If they ask you to recommend a specific product, there's really none that the FDA says you can use. But what the FDA has is the companies to stay away from. So if you're interested, you can go to that link and you can look at some of them. So when your patient comes to you and asks you, you can tell them to stay away from those companies. But that doesn't mean that the ones that are not on the list are better. It's just so happened that these ones are the ones that, for one reason or the other, their product came to the front line, and the FDA issued a warning letter for the community to stay away from those products. But in any case, if you're going to use marijuana for medical purposes, you want to use that cautiously, even with the ones that have been FDA approved. A lot of patients that were prescribed those medications did not take the medications for long because they did not like the way it made them feel. They did not like the euphoria. They did not like the just the general feeling of it. And so a lot of people on Marinol, Sissamet, did not take it for a long time because they did not like the side effects of the medication. And I'm available if you have any questions regarding the use of marijuana for medical use. If you have any questions about substance use disorder or marijuana use disorder, yes, there is something called marijuana use disorder. For now, there's no medication for it. All they have is psychotherapy to help with marijuana use disorder. Feel free to give me a call. Feel free to email me, and I'll be more than happy to answer any questions that you may have regarding the use of marijuana. And on the legal side of things, I decided not to put it on here. For those of you who practice in states where marijuana use is legal, you might want to refer to your state because it's different for every state. Thank you so much for your time.
All right. Thank you so much, Dr. Ashutentang, for that wonderful presentation. At this time, we currently kind of out of time, but if we do have any questions, you can probably type them in the message box and we'll have Dr. Ashutentang answer to those questions. Um, However, I will make her contact available to via the message box. So if you have questions, you can also contact her. In the meantime, thank you guys so much for participating in this presentation today. We are all looking forward to 2020, hopefully with a better platform that can accommodate more devices, especially the cell phones, hopefully, and then on different topics to address next year. So thank you guys so much. And if you do have any questions, go ahead, type them in the message box. We'll have maybe the next 5 minutes or so. We can have Dr. Ashutentang answer those questions. Thank you. So yes, if you do have any questions in the next 5 minutes or so, you can go ahead and type in your questions, and she will respond to them as quickly as possible. Okay, thank you, everyone. So if there are any questions, please, Dr. Ashanten's email is actually in the message box, and it's also she also sent her number, which is 704-905-2537. So you can actually contact her with any questions you have. We will go ahead and close the event, and thank you so much for being a part of it. And Happy New Year 2020.